looked at the data of Adagrasib in combination with Pembrolizumab. This is from a smaller study, and it's very early data, so take it with a grain of salt. We saw response rates, very excitingly here, of about 49-50%. And what was more important is that the toxicity rate was relatively low. So liver toxicity in that 5 to 10% range. More recently, at AACR, which occurred right before ASCO, we saw data from LY982, also in combination with Pembrolizumab in the frontline. Very small subset of patients here, 9 patients, but a 78% response rate. More importantly, on the right, the treatment-related adverse events were low, and really no liver toxicity was seen with this combination. So in conclusion, KRAS G12C alterations are common. They occur about 12% of non-small cell lung cancer. They can also occur in other histologies, such as colorectal, but at much lower rates. And really, broad panel next-generation sequencing is critical for identification. We know that we now have novel small molecule inhibitors that block the cysteine residue. Sotorasib and Adagrasib are FDA approved in the second line setting. So that's after progression on chemotherapy and immunotherapy. And we know that the response rates range between 30 and 50%. So we need to do better in this patient population. The progression-free survival, how long patients are on these medicines before the disease starts to grow, is still poor. It's only 6 to 7 months. So thinking about combinations and thinking about the development of the next generation KRAS inhibitors will be important. Resistance here is inevitable, and it's important to understand if you have resistance, just like in EGFR, what is the type of resistance? Is it a point mutation in RAS, an on-target mutation, or is it a bypass track or off-target resistance? And then lastly, toxicity and tolerability. I think we need to do better here as well.